Welcome to the Deep Dive. Today we're tackling a really important topic, arterial aneurysms. Simply put, we're talking about blood vessels that have sort of ballooned out, a dilatation of at least 50% compared to their normal size.
Yeah.
It's more common than you might think, and the consequences can be, well, incredibly serious.
Absolutely. And while aneurysms can, pop up anywhere in our arteries, the abdominal aortic aneurysm, or AAA, that's a major concern.
Right, AAA.
Yeah. In the U.S., back in 2017, these were linked to almost 10,000 deaths. It's a big number.
Wow.
That's why around 120,000 preventative procedures are done annually trying to catch these before they rupture, before they become life-threatening.
That's a huge figure. And while AAAs get, a lot of the attention, it's crucial to remember that aneurysms in other spots can also cause big trouble.
Definitely.
We're talking about potential blood clots breaking off, causing blockages elsewhere.
Yeah.
That's an embolism, right?
Exactly, embolism. Or a clot can form right in the aneurysm itself, leading to thrombosis. Plus, these bulges, they can just press on nearby organs, causing compression issues. So, yeah, lots of potential problems.
So it's not just about having an aneurysm.
No, not at all. It's about what that aneurysm is like. Size is obviously key.
Mm-hmm.
Its actual diameter and how that compares to the artery's usual size.
Uh-huh.
But we also need to know what kicked things off in the first place. The etiology, they call it, how fast it's growing, and importantly, its shape.
Shape?
Yeah. Is it a more even, all-around widening? We call that fusiform.
Fusiform, okay.
Or is it more of a localized bulge, like an outpouching that's known as saccular?
Fusiform and saccular, got it.
Yeah.
And it's wild to think that this isn't just a modern problem, is it?
Not at all. It puts things into perspective, really.
Our sources actually mention the Ebers Papyrus from ancient Egypt. Way back, like 2000 BCE. It seems to describe something very much like an arterial aneurysm, and even suggest a pretty intense treatment involving, well, knives and fire.
Yeah, pretty drastic, but it shows they recognized something was wrong there.
Right. Then fast forward quite a bit, and we see some real headway. Antilles, a physician in the early centuries AD.
Right, Antilles. He figured out that controlling blood flow was key, at least for limb aneurysms.
How do you do that?
Well, he'd tie off the vessel above and below the bulge ligation and then pack the aneurysm itself. Pretty clever for the time.
And then John Hunter in the 18th century. He brought more science to it.
He did. A more scientific approach. He successfully tied off the femoral artery for a popliteal aneurysm that's behind the knee. But crucially, he did it in a way that still allowed blood flow to the leg through other routes, collateral circulation.
That's a big step, and the progress just kept coming. Right? From Rudolf Modus pioneering a way to repair aneurysms from the inside.
Endo-aneurysmorphy, yeah. Late 1800s, trying to fix it from within the aneurysm sac itself.
To the first successful aortic ligation in 1923. And then the big shift in the mid-20th century with graft replacement.
Yeah, using synthetic materials, like Vignon N, which, interestingly, had a connection to World War II parachute material, I believe.
Huh. No kidding?
And what's truly impressive is how quickly things have advanced recently, especially with endovascular repair coming in the early 1990s.
That's the less invasive method.
Exactly. Doctors insert stents and grafts through catheters, much less open surgery. Now it's estimated that it accounts for, over 70% of all aortic aneurysm treatments? A huge shift.
Okay. So with all that history as a backdrop, our mission today, as we dig into these medical textbook chapters, is to really get a handle on the different aspects of arterial aneurysms.
Sounds good.
Let's start with how we actually define them by size. That 50% increase is the general rule, but it seems there's more to it, right?
Absolutely. It's a good starting point, but it gets more specific. When we look at aortic aneurysms, for instance, there was a key Swedish MRI study.
Oh, yeah?
Yeah, they focused on 70-year-old men and women to really pinpoint what size and what ratio compared to normal would be considered aneurysmal in different parts of the aorta.
How did they define that?
They used a statistical measure, 2 standard deviations above the average diameter for that specific location and sex.
Okay, makes sense.
So, for example, for the infrarenal aorta, that's the bit below the kidneys, they found that in men, an aneurysm was typically a diameter of 3.0 centimeters, or a ratio of 1.1 times the normal size for that man.
Right.
In women, it was a bit smaller, 2.7 centimeters, or a ratio of 1.0, basically double the normal width.
So it varies by location and by sex.
Exactly. They have specific numbers for the ascending aorta near the heart, the descending part, the bits above the kidney arteries, all laid out in tables in the source material. So it's not just one number fits all.
That makes sense. And what about aneurysms in other parts of the body, like not the aorta?
Right. Well, after the aorta, aneurysms in the iliac arteries in the pelvis, the popliteal arteries behind the knee, and the femoral arteries in the thigh are the next most common.
And they often show up together.
Yeah, that's important. They often coexist with aortic aneurysms. If you find one, you often look for the other. And the sources give us some typical normal diameters for these other arteries too, like the celiac artery supplying abdominal organs, usually around half a centimeter.
Tiny.
Relatively, yeah. Superior mesenteric, maybe 0.6 centimeters. Down in the leg, common femoral artery, roughly 0.8 centimeters. Popliteal, around 0.9 centimeters.
So the popliteal is normally bigger than the femoral.
Typically, yeah, a little bit. And then the tibial artery way down in the lower leg is only about 0.3 centimeters, gives you a benchmark to understand what a 50% increase actually means in these different vessels.
Okay, so size is a really important factor in defining an aneurysm. Nailed that. Now, our sources also make this distinction between true and false aneurysms or pseudoaneurysms.
Right.
What's the key difference we need to understand there?
The crucial difference lies in the layers. Which layers of the artery wall are actually involved in the bulge?
Okay.
In a true aneurysm, all three layers of the vessel wall, the intima, media, and adventitia, they stretch and balloon out together. Think of it like blowing up a whole intact balloon.
Right, the whole structure expands.
Exactly. A false aneurysm or pseudoaneurysm is different. Here, there's actually a hole or a disruption in the artery wall.
A leak.
Sort of, yeah. The bulge isn't the wall itself expanding. It's a collection of blood that's leaked out but is being contained by the surrounding tissues, or maybe just a blood clot forming a boundary.
Ah, I see. So it's not the actual vessel wall ballooning out.
Precisely. It's contained hemorrhage, basically.
And these pseudoaneurysms, especially in the arms or legs, they often have a specific trigger, don't they?
Yes, very often. Peripheral pseudoaneurysms are frequently iatrogenic.
Meaning caused by medical procedures.
Exactly. Like when doctors need to access arteries for things like angiograms, putting in catheters, placing stents, they make a puncture. Sometimes that puncture site doesn't seal properly and a pseudoaneurysm forms.
Okay.
There's often a neck, which is like a narrow channel connecting the main artery to this blood-filled cavity outside. If that neck is there, treatments aimed at clotting off the pseudoaneurysm, like injecting thrombin or using compression, can be quite successful.
And our sources also mention pseudoaneurysms that can happen after surgery.
That's right. You can get them at surgical anastomosis.
The joints.
Yeah, the points where a graft, like a bypass tube, is sewn onto a blood vessel. If those suture lines weaken or break down over time, maybe due to infection or just wear and tear, you can get a pseudoaneurysm forming right there at the joint. We call them perianastomotic.
And can those be fixed?
Yes. Endovascular techniques have become incredibly helpful here too. Often you can go in with catheters and place a covered stent across the defect to seal it off from the inside. Much less involved than redoing the whole open surgery sometimes.
Okay, so we've got a handle on size and the true versus false distinction. Now let's talk about location and how widespread these enlargements can be. I came across terms like ectasia and arteriomegaly.
Right.
What do those tell us?
Okay, so ectasia is when an artery is abnormally enlarged, but it doesn't quite hit that 50% increase mark that defines an aneurysm. It's more like a slight diffuse widening.
Just generally a bit bigger than normal.
Yeah, exactly. Arteriomegaly, on the other hand, that describes a more extensive diffuse enlargement. It affects multiple segments of the arterial system, and in this case, the dilation does exceed that 50% threshold in those segments.
So multiple parts of the body's arteries are enlarged.
Correct. But it's important to remember, arteriomegaly is really a descriptive term. It tells us there's widespread enlargement, but it doesn't by itself point to a specific underlying disease. It's more like saying, this person has generally large arteries.
And this more widespread enlargement, it has implications beyond just the individual vessels, doesn't it? Thinking about family history.
Absolutely. That's a key point. Both having aneurysms and having this arteriomegaly are associated with a higher chance of other close family members, first-degree relatives like parents, siblings, kids, also developing aneurysmal disease.
Interesting.
And the term aneurysmosis is sometimes used. That describes someone who has multiple aneurysms in different parts of their body, or they have this widespread aneurysmal degeneration happening along with arteriomegaly. It suggests a more systemic underlying tendency.
Okay, that makes sense. Let's move on to morphology of the shape. We mentioned fusiform and saccular earlier. Can you paint a clearer picture?
Sure. Picture a normal, straight blood vessel, like a tube. A fusiform aneurysm is like that tube expanding pretty uniformly all the way around its circumference. It creates a kind of spindle or, American football shape, and even symmetrical widening.
Okay, like the whole pipe bulges out evenly.
Pretty much, yeah. Now, imagine a different scenario. A saccular aneurysm is more like a blister or a small pouch that balloons out from just one side of the artery.
Oh, so not symmetrical.
Right. It's a localized, often eccentric, meaning off-center defect. It typically happens because there's a weakness in just one specific spot in the vessel wall, maybe due to an old injury or an infection or a specific type of ulceration in the wall.
So it seems most of the aneurysms we see in the arms and legs, the peripheral ones, are linked to atherosclerosis, hardening of the arteries.
Often, yes.
And they tend to be that fusiform type, or maybe what's called concentric saccular, still kind of all around, but maybe not perfectly even.
That's generally true for degenerative peripheral aneurysms.
But then we have examples like aneurysms in the kidney arteries or in the brain, which often have that more distinct, localized saccular shape.
That's a really key distinction, yes. The cause often relates to the shape. Fusiform aneurysms usually develop because the entire circumference of the artery wall has weakened over time, maybe due to those degenerative processes we'll talk about.
Right.
Saccular aneurysms, however, often arise from a very specific localized weakness, maybe a small tear or a partial break in the wall layers, things like penetrating atherosclerotic ulcers.
What's that?
That's where plaque buildup kind of erodes through the inner layers of the artery, or intramural hematomas that's bleeding within the artery wall itself. These focal weaknesses can bulge out and form a saccular aneurysm.
And does the shape itself tell us anything about the risk or how we might treat it?
That's a good question. We have a pretty solid understanding of the rupture risk for fusiform aneurysms based on their size, especially AAAs.
Yeah.
It's less clearly defined for saccular ones just based on shape alone. However, the fact that an aneurysm is saccular often makes doctors consider intervention, fixing it, at a potentially smaller size than they might for a fusiform aneurysm in the same location. There's often a concern about that focal weakness.
So maybe more likely to rupture, even if smaller.
Potentially, or at least the thinking leans that way sometimes. But ultimately, the decision to repair a saccular aneurysm really depends on a combination of factors. Is the patient having symptoms? How big is it? How quickly is it growing? And crucially, is it technically feasible to repair it safely?
Right, the whole picture. Okay, let's get into the why, the etiology. Our sources start by talking about degenerative aneurysms. What's the story there?
Right, degenerative. These are by far the most common type we see. You'll often hear them called atherosclerotic aneurysms as well.
Because they happen with hardening of the arteries.
Yeah, because atherosclerosis is frequently present in the same patients. However, some experts actually prefer the term degenerative because the direct cause and effect link isn't perfectly proven. It's probably more complex than just atherosclerosis causing the bulge.
So what is going on?
Well, what we see in degenerative aneurysms is often an imbalance in the artery wall. There seem to be higher levels of certain enzymes called metalloproteinases, MMPs.
Yeah.
These enzymes can break down the structural proteins like collagen and elastin that give the artery wall its strength. At the same time, there's evidence of lower levels of the things that normally keep these enzymes in check: protective enzymes, antiproteolytic enzymes, specifically one called TIMP1.
So too much breakdown, not enough protection.
That seems to be a key part of the degenerative process. Yeah. Weakens the wall over time.
And lifestyle choices play a big role here, don't they?
Oh, absolutely. Yeah. Smoking. That is by far the most significant modifiable risk factor.
For developing them and for them growing faster.
Yeah, both. Smoking is strongly linked to development and growth rate, so quitting smoking is absolutely critical for anyone at risk or diagnosed with an aneurysm.
Makes sense.
And we're also learning more and more about the role of inflammation. Chronic inflammation in the artery wall seems to be deeply involved in both the development and the progression of these degenerative aneurysms.
Okay. Then we have specifically inflammatory aneurysms. How are those different from the degenerative ones we just discussed?
Inflammatory aneurysms are kind of a distinct subset. They're characterized by a really exaggerated inflammatory response, much more intense than the background inflammation in degenerative ones.
And what does that look like?
It leads to a significant buildup of fibrous, scar-like tissue around the aneurysm. The most common spot for these is, again, the infrarenal abdominal aorta.
Below the kidneys.
Right. On scans, like a CT scan, you can often see this thick inflammatory rind encircling the aorta. It looks quite different.
And that causes problems.
It can. This inflammation can sometimes trap or involve nearby structures. The ureters, the tubes carrying urine from the kidneys, they run right nearby and can get squeezed or blocked by this inflammatory mass.
Ouch. So is the underlying cause different genetically?
You'd think so, right? But interestingly, despite how different they look, genetic studies haven't yet found major differences in the underlying genetic predispositions between standard degenerative and these inflammatory types. So current research is really focused on looking at the specific types of immune cells involved, the signaling molecules, cytokines that are present, trying to figure out why this intense inflammation happens in some people.
And are they harder to treat?
Surgically, yes, they can be more challenging. During traditional open surgery, trying to dissect the aneurysm free from all that surrounding inflamed, stuck-together tissue can be tricky. There's a higher risk of accidentally injuring nearby organs like the duodenum, part of the bowel, or the ureters.
Right.
However, endovascular repair, fixing it from the inside with a stent graft, has shown some promise. There's even some evidence it might lead to a decrease in that surrounding inflammation and fibrosis over time, though that's still being studied.
Our sources also list several other inflammatory arterial conditions that could be associated with aneurysms, like specific diseases.
Yes, exactly. Conditions like Takayasu arteritis, giant cell arteritis, polyarteritis nodosa, Beset disease, Cogan syndrome, these are systemic inflammatory diseases that primarily affect blood vessels.
And they can cause aneurysms.
They can, yes. And also conditions like cystic medial necrosis, which is a degeneration in the middle layer of the artery wall, often seen in connective tissue disorders. In these cases, the aneurysm formation is really a complication of the underlying inflammatory or degenerative process affecting the vessel wall. Management often focuses on controlling that underlying disease, usually with medication.
Okay. Moving on, we have aneurysms associated with arterial dissection.
Yeah.
We hear about aortic dissections quite a bit. How do they relate to aneurysm formation?
Right. Dissection is a serious event. It starts with a tear in the innermost lining of the artery, the intima. This tear allows blood to get between the layers of the artery wall, usually splitting the middle layer, the media. It creates a false channel where blood flows parallel to the main one.
Scary.
Very. Now, if this initial tear doesn't propagate, doesn't spread far, it might just lead to what's called a penetrating aortic ulcer or an intramural hematoma, basically, localized damage or bleeding within the wall.
Okay.
But if it does propagate, the pressure of the blood flow and the stretching of the artery wall are the main forces driving it along the vessel. Symptomatic dissections most commonly happen in the ascending aorta, right near the heart, or the descending aorta further down the chest.
And how does that lead to an aneurysm?
Well, the artery's strength comes from its intact three-layered structure. A dissection fundamentally weakens that structure. So it can lead to problems acutely, like blocking off branch arteries, or over time it can lead to aneurysm formation. Either the weakened outer wall can rupture acutely, or, more commonly in chronic cases, the dissected segment gradually dilates and expands over months or years, forming an aneurysm.
Oh, okay.
And once these chronic post-dissection aneurysms form, they're generally managed using the same criteria as degenerative aneurysms based on size, growth rate, and symptoms.
Got it. Then we have traumatic aneurysms. These sound pretty self-explanatory.
In essence, yes. They're usually pseudoaneurysms, remember? Not true aneurysm.
Right, the contained leak.
Exactly. They result from an injury, a stab wound, a blunt trauma impact, even a complication from a medical procedure that perforates or tears the artery. Instead of free, uncontrolled bleeding, the hemorrhage gets contained locally by the surrounding tissues, forming that pseudoaneurysm sac.
And the location just depends on where the injury was.
Pretty much, yeah. Common sites of trauma or arterial access.
Okay. Then there are developmental and congenital anomalies. This category sounds like it covers a wide range of issues.
It does. Aneurysms link to abnormalities in how the heart or arteries develop in the first place. They're not super common overall, but they are quite diverse depending on what the original defect was.
Like what?
Well, these aneurysms are essentially one way that the original developmental issue can show up later in life. One example mentioned is a persistent sciatic artery.
What's that?
Normally, the main artery to the leg shifts during development. If the primitive sciatic artery doesn't regress properly, it persists as the main vessel. And in those cases, over 40% of individuals will go on to develop an aneurysm in that abnormal artery.
Wow.
Any others? Another example is a comparel diverticulum. That's a small aneurysmal pouch at the origin of an abnormally placed right subclavian artery arising from the descending aorta. It can sometimes worsen swallowing difficulties if it compresses the esophagus.
And congenital AAAs, aortic aneurysms from birth.
They're rare, but they have been reported, sometimes linked to conditions like tuberous sclerosis, but sometimes occurring even without other specific syndromes. Suggests an inherent weakness in the aortic wall itself in some individuals.
And genetics plays a role beyond just these specific congenital disorders, doesn't it? We touched on family history earlier.
Absolutely. Even outside specific name syndromes, the familial link is strong. If you have a male sibling, especially who's had an aortic aneurysm, your own risk is significantly higher.
How much higher?
The sources suggest somewhere around 20% to 30%, which is a big jump compared to the general population risk of maybe 5% or so. This strongly points to a genetic component, even if we don't fully understand all the genes involved yet.
So screening family members makes sense.
It's definitely something strongly considered, yeah. Siblings and children of affected individuals.
Okay. Finally, in the etiology section, we have infectious or mycotic aneurysms. That term mycotic sounds like fungus.
Yeah, it's a bit of a historical term. It originally referred to fungal infections, but now it's generally used for any aneurysm caused by any infection in the artery wall, bacterial, fungal, or otherwise.
How does an infection cause an aneurysm?
Two main ways. Either microorganisms traveling through the bloodstream get lodged in the arterial wall and start an infection there, that's primary infection, or an infection in adjacent tissue, like an abscess or infected lymph node, can spread and directly erode into the artery wall.
Okay.
Most primary infected aneurysms, meaning the infection started in the artery, rather than infecting a pre-existing aneurysm, tend to have that saccular shape we talked about.
The pouch-like one.
Exactly. So if a doctor sees a saccular aneurysm, especially if there are signs of infection like fever or pain, they'll have a higher suspicion that it might be infectious and investigate further.
What kind of bugs cause these?
A whole range. Various bacteria like staph and salmonella are common. Fungi like candida and aspergillus, especially in immunocompromised patients. Also, less commonly now, things like tuberculosis and syphilis used to be major causes.
And who's most at risk?
We see them more commonly in people who inject drugs, unfortunately, due to contaminated needles introducing bacteria into the bloodstream. Also in individuals with weakened immune systems, transplant recipients, people with HIV, patients on long-term steroids.
And treating these must be tough, right? With the infection.
They certainly present unique challenges, yeah. Using standard prosthetic graft material, the plastic tubes we normally use for repair, is generally a bad idea in an active infection because the bacteria can stick to it and create a persistent problem.
So what do you use?
That's the difficulty. There aren't many readily available, durable alternatives using the patient's own tissue, autogenous. Open surgery is also more complicated because the infection causes inflammation, making the tissues fragile and dissection difficult.
Are there any options?
People are working on it. Using antibiotic-soaked grafts, using cryopreserved allografts arteries taken from deceased donors and specially treated and sometimes even trying primary endografting, placing a stent graft despite the infection, often with long-term antibiotics. But sadly, the rates of complications and mortality for patients with infected aneurysms remain quite high. It's a very serious situation.
Okay, wow. That covers the why. Let's shift focus now to aneurysms in specific arteries. We've talked a lot about the aorta, especially infrarenal AAAs being most common. What else should we know about aortic aneurysms in different spots?
Right. So aneurysms in the ascending aorta, the part right out of the heart, are often related to degeneration of the wall, maybe linked to high blood pressure or conditions like Marfan syndrome, or they can be a consequence of an aortic dissection, as we discussed. The aortic arch, where the vessels to the head and arms branch off, and the descending thoracic aorta can be similarly affected by degeneration or dissection. Interestingly, though, aneurysms that only involve the thoracic aorta, the chest part, are less common overall than AAAs. Only about 3% of all aneurysm repairs in the U.S. are for isolated thoracic aneurysms.
And AAAs become more common with age.
Definitely. The prevalence really climbs. About 1.7% of women and 5% of men over 65 have an infrarenal aortic diameter over that 3-centimeter threshold, and that risk goes up by about another 6% for every decade after 65.
And thoracoabdominal ones, involving both chest and abdomen.
Those are less frequent but are considered some of the most complex challenges in vascular surgery due to the involvement of critical arteries branching off to organs like the kidneys, intestines, and spinal cord.
Okay. What about the iliac arteries, the branches going into the pelvis and legs?
Iliac aneurysms are most common in the common iliac artery, the first main branch off the aorta's end. And quite often, maybe 80–90% of the time, they occur along with an infrarenal AAA. Isolated iliac aneurysms are less common.
So if you have an AAA, check the iliacs and vice versa.
Pretty much standard practice. After the common iliac, the internal iliac arteries, which supply blood to the pelvic organs like the bladder and rectum, are the next most frequent site. These also often occur with common iliac aneurysms.
Are isolated internal iliac ones dangerous?
They can be, yes. The sources mention a relatively high risk of rupture, around 40%, and a significant mortality rate, maybe 31%, if they rupture when isolated, so they are taken seriously. External iliac aneurysms, the ones continuing down towards the leg, are quite rare and usually related to trauma or non-degenerative causes.
Okay, moving further down the leg. Femoral and popliteal aneurysms, key things there.
Right. True aneurysms of the femoral artery in the thigh are relatively uncommon. When they do occur due to degeneration, studies suggest they often don't cause symptoms or major problems unless they get pretty big, maybe larger than 3.5 centimeters, or if a blood clot forms inside them.
Do they happen alone?
Often not. These degenerative femoral aneurysms frequently happen in both legs, maybe 26% of cases are bilateral. And a very high percentage of patients, like 88%, will also have another aneurysm somewhere else, often in AAA or a popliteal.
So again, look elsewhere.
Always. A more serious issue with femoral arteries can be infected pseudoaneurysms, often linked to IV drug use in the groin area. Those carry significant risk. And as we mentioned, non-infected femoral pseudoaneurysms are also relatively common after catheter procedures or bypass disruptions in the groin.
And what about the popliteal artery, behind the knee?
Popliteal aneurysm is actually the most common type of peripheral arterial aneurysm, meaning outside the aorta and iliacs.
Really? More common than femoral?
Yes, true popliteal aneurysms are more common, affects about 1% of men between 65 and 80. They are very frequently bilateral in both legs, and again, very commonly occur together with aortic aneurysms. So if someone's diagnosed with an AAA, checking the popliteal arteries with ultrasound is standard.
And the risk is different from AAA. You mentioned rupture for AAA.
Exactly. While popliteal aneurysms can rupture, it's much less common than with AAAs. The primary danger with popliteal aneurysms is acute thrombosis, a sudden clot forming inside the aneurysm.
Blocking blood flow.
Yes, blocking flow to the lower leg and foot. This can cause severe ischemia, lack of oxygen, and potentially lead to limb loss if not treated very quickly. So the main threat is limb viability, not necessarily immediate death from rupture like in AAA.
Different beast entirely. Okay, our sources also discuss visceral aneurysms affecting arteries to the abdominal organs.
Right, visceral artery aneurysms. Estimated to occur in about 1% of the population, so not super rare, but not as common as aortic or popliteal.
Which ones are most common?
Aneurysms of the splenic artery, the one going to the spleen, are the most frequent type here. Make up around 60% of all visceral aneurysms.
Any patterns there?
They're seen more often in women, also associated with portal hypertension, which is high pressure in the liver circulation, often from cirrhosis. And importantly, pregnancy is a specific risk factor for rupture of splenic artery aneurysms.
How are they treated?
Many visceral aneurysms, including splenic, can often be treated using minimally invasive endovascular techniques. Going in with catheters to place coils or covered stents to block off the aneurysm.
Unless
the aneurysm involves the hilum of the spleen, where the artery branches right as it enters the organ. In those cases, surgical removal of the spleen, a splenectomy, might be needed to deal with the aneurysm safely.
Okay. What about the renal arteries to the kidneys?
Renal artery aneurysms are less common, maybe 0.1% of the population. They're often saccular, that pouch-like shape, rather than fusiform.
Any specific cause?
They can be linked to a condition called fibromuscular dysplasia, FMD, which affects the artery walls, particularly in younger women. But they can also result from atherosclerosis, trauma, infection, the usual suspects.
What are the risks with renal artery aneurysms?
Potential risks include thrombosis or embolism clots forming or breaking off. They can sometimes cause uncontrolled high blood pressure. And although rare, rupture is a risk, and it's particularly dangerous if it happens during the third trimester of pregnancy.
When would they be repaired?
Recommendations often suggest repair for those larger than maybe 2 to 3 centimeters, those found in women of childbearing age due to the pregnancy risk, or if they're causing problems like refractory hypertension, flank pain, or blood in the urine. Though the exact size cutoff is still debated a bit, both endovascular and open surgery are options.
We also have extracranial cerebrovascular aneurysms, arteries to the brain, but outside the skull.
Right. Compared to aneurysms inside the skull, which neurosurgeons deal with, these extracranial ones are quite rare.
Where do they happen?
When they do occur, the carotid artery in the neck is the most common spot, usually the internal carotid more so than the common or external carotid branches. Also, as mentioned before, a dissection following trauma can sometimes lead to aneurysm formation later on in both the carotid and the vertebral arteries in the neck.
And finally, upper extremities, arms.
Not very common locations for true degenerative aneurysms. Subclavian artery aneurysms up near the collarbone can sometimes result from repetitive trauma associated with thoracic outlet syndrome compression of the vessels and nerves there.
Okay.
The other type we see with some frequency in the arm is an iatrogenic brachial pseudoaneurysm. That's a false aneurysm in the brachial artery at the elbow, usually happening after a medical procedure involving arterial access there, like for cardiac catheterization or sometimes dialysis access procedures.
It's really striking how many different places these can pop up.
Yeah.
Our sources also discuss having multiple aneurysms in the same person. Is that common?
It's definitely a well-known association, especially between infarenal aortic, thoracic aortic, and popliteal aneurysms.
Right, you mentioned that linkage.
Yeah, Dr. Crawford, a famous aortic surgeon, noted that over half his patients with thoracic aneurysms also had abdominal ones, and about 12% of his abdominal patients also had thoracic ones. So there's overlap.
But needing surgery for multiple ones at once isn't that common.
According to one study cited from the Mayo Clinic, patients needing surgery specifically for multiple aortic aneurysms only made up a small percentage, around 3.4% of all their aneurysm procedures. So, while the association exists, simultaneous complex repairs might be less frequent.
Unless you have certain conditions.
Exactly. Patients with specific connective tissue disorders, like Marfan syndrome or Ehlers-Danlos syndrome, have a significantly higher chance of developing multiple aneurysms in different locations over their lifetime. They often experience recurrent aneurysmal disease and need regular, lifelong surveillance.
And what about in the peripheral arteries, like the legs? Multiple sites there.
Popliteal aneurysm really stands out again here. It's the peripheral aneurysm most likely to occur bilaterally in both legs simultaneously.
Ah.
And as we said, it's also very commonly seen alongside AAAs. One review mentioned 59% of popliteal aneurysm patients had them in both legs, and about half also had in AAA.
And other peripheral ones.
Yeah.
Femoral, etc.
Less likely to occur in multiple sites synchronously, it seems. The suspicion for finding, say, a femoral aneurysm if you find one in the other leg isn't as high as it is for popliteal, or for finding another aneurysm if you find a popliteal or in AAA.
Okay. We've touched on genetics a few times. Just to reiterate, how strong is that general familial link for developing aneurysms outside specific syndromes?
It's significant. If you have a family history of aneurysm disease, particularly in AAA, your own risk of developing one is estimated to be about 30% higher.
Even if there's no known Marfan or Ehlers-Danlos?
Yes, even for the more common degenerative AAAs. While we don't fully understand all the specific genes involved in these non-syndromic cases yet, having that family history is considered the most common risk factor, apart from things like smoking and age.
So again, screening relatives is important.
Yes, it definitely warrants consideration, especially for first-degree relatives like siblings and children.
And those specific connective tissue disorders, Ehlers-Danlos, Marfan, Loeys-Dietz, they are primary drivers of familial aneurysmal disease, aren't they?
They absolutely are. They represent the clearest examples of genetically driven aneurysm formation. These conditions require careful genetic characterization, often genetic counseling, because they usually affect multiple body systems, not just the arteries.
And genetics is likely to change things.
Hugely. As our ability to sequence and analyze an individual's entire genetic code gets better and cheaper, it's likely to transform how we diagnose these conditions, identify people at risk much earlier, and potentially even guide management strategies in the future.
Our sources also specifically mention cystic medial degeneration. This relates to familial thoracic aortic aneurysms.
Yes, it's a pathological finding, a specific type of degeneration seen in the middle layer, the media, of the aortic wall. It's often found in cases of familial thoracic aortic aneurysm syndrome, even when there isn't a diagnosis of Marfan or another well-defined connective tissue disorder.
And there's a link to a heart valve issue.
That's another important connection. A bicuspid aortic valve, where the main heart valve leading to the aorta has only 2 leaflets instead of the usual 3, is relatively common, maybe 1–2% of the population, and it's strongly linked to the development of ascending aortic aneurysms.
And those aneurysms often show this degeneration.
Yes, tissue biopsies from aneurysms associated with bicuspid valves frequently show cystic medial degeneration. There's also Turner syndrome, a genetic condition in women, which is associated with an increased risk of ascending aortic aneurysm dissection and having a bicuspid aortic valve. So these things cluster together.
It's clear that managing aneurysms is just incredibly complex and constantly evolving. The final section in our sources touches on current aneurysm management. What are some key advancements we've seen?
There have been truly significant strides really across the board. A lot of it comes from a much better understanding of the natural history, how these aneurysms behave if left untreated, which helps us pinpoint when intervention is actually most beneficial.
So a better timing of treatment.
Better timing, yes. We also have much better ways to manage the risk factors involved, like smoking cessation programs, blood pressure control, statin use. Diagnostics have improved hugely with the CT, MRI, ultrasound. We have more precise ways of classifying aneurysms, which helps in comparing outcomes and deciding on treatment. And of course, the treatment options themselves have expanded dramatically.
Open surgery and endovascular.
Right. We still have traditional open surgical repair, which is very effective but invasive. But now we have this whole range of increasingly sophisticated endovascular techniques using different types of stent grafts, TVAR for thoracic aneurysms, FEVAR, which is fenestrated endovascular repair for complex abdominal aneurysms involving kidney or gut arteries, branched grafts. The technology is constantly improving.
And follow-up.
That's become much more standardized, too. Clearer guidelines for surveillance imaging after treatment, better ways to classify any complications that might arise, and establish criteria for when a reintervention might be needed if the initial repair has issues down the line.
So there are guidelines and standards now.
Absolutely. Given all this activity and research, there are now established reporting standards for clinical trials and outcomes. Major vascular surgery societies, like the SVS in the US and European societies, publish comprehensive, evidence-based practice guidelines. The SVS guidelines for AAA, for instance, are mentioned as having numerous recommendations based on the highest level of evidence.
And resources for patients.
Yes, that's important too. There are more patient-oriented resources and manuals available now to help individuals understand their condition, the risks and benefits of different treatments, and make informed decisions alongside their doctors.
This has been a truly deep dive into the world of arterial aneurysms. It's remarkable, really, how these dilatations, defined by that seemingly simple 50% increase, are influenced by such a complex mix of factors.
It really is. Genetics, lifestyle, the specific location, underlying conditions, it all plays a part.
The information we've explored today, it really provides, I think, a solid foundation for understanding this pretty significant health issue.
Absolutely, and it underscores the continuous progress being made in how we diagnose and manage it. Hopefully, for anyone listening who knows they have risk factors or maybe has a family history, this discussion highlights the importance of awareness.
Yeah, and thinking about maybe talking to their doctor about screening.
Exactly.
As we wrap up, thinking about that long history, from ancient Egypt trying to figure this out, all the way to these incredible endovascular techniques and the genetic insights we're gaining. It really makes you wonder, doesn't it? What might the landscape of aneurysm prevention and repair look like in the decades to come? Could we move beyond just repair to actual prevention based on genetics or targeted therapies?
That's the hope, isn't it? A fascinating thought to end on.
Definitely something to think about. Thanks for joining us on this deep dive.